Good afternoon to everyone present here with us today. This is your ICP, today's topic. I'd like to welcome everyone who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Murugan Shankaranatham. Sir is Senior Consultant in HIV and Sexual Medicine, Tamil Nadu, former National President of Indian Association for the Study of Sexually Transmitted Disease and AIDS. Now, with the help of Sir and his wonderful insight, we'll be taking a close look on today's topic, which is role of ART drugs in the prevention of HIV infection. Now, without any further delay, I would like to welcome Sir again at our forum and would like to hand over the session to him. Over to you, Sir.
Good afternoon, everybody. Thank you, Syrian and IGCP, for giving me this platform and wonderful introduction. And let us talk about today's World AIDS Day. It's appropriate to talk about this very important topic: the role of antiretroviral drugs in the HIV prevention, especially HIV prevention. So this is a 38th World AIDS Day. Every 1st December is being observed as AIDS Day since 1988 onwards. Every year they form a theme, and as per the theme, they are moving their steps to make awareness, to make the halt to the epidemic, like that. So this year the theme is overcoming disruption, transforming response, put forth by UNAIDS and WHO. And another, that is the AIDS Society of International AIDS Society, also put as a theme like that, related and connected theme, that is rethink, rebuild, rise, put forth by the International AIDS Society. So these are the themes for this year. Michael Gottlieb is an American doctor. He's the one first who proclaimed that HIV or AIDS, not HIV, is the AIDS, acquired immunodeficiency syndrome, was first reported to burial system of the US. So he is the man. In the 1980s, late 1980s and 81, some abnormal infections like pneumocystis carinii, before now Gerosia, pneumonia, and Kaposi sarcoma, which is not so common to get in US previously, and all of them were having immunodeficiency. All of them were found to be all MSM, that is homosexuals, and he's the man first reported. And at that time, the causative organism was not known. HIV was not known. Only, so this is a causative organism virus, human immunodeficiency virus, which was first discovered and reported by one French scientist and another American, Robert, and that is both of them are contributing there, or there is HIV virus. In 1983 December, in Louis Pasteur's Institute and Bethesda Institute in 1984 January, more or less same, but the name date is different. That is Louis Pasteur Institute. They put it as a HCLV3, and these American scientists also named is different. But later, 1985 only, it was anonymously, uniformly called as human immunodeficiency virus. Is HIV management in the past? It was before ART. Sorry, I put my um, slide sharing in a different way. So I have to change it. This is a management ART role, but I am not going. Sorry, I wrongly shared. I will stop sharing and I will go through it, and then I will come back. Sorry, excuse me. Shireen, will you help me?
So your slides are visible. Am I
I'm
audible to you?
sorry for the wrong. So now it is correct. So HIV prevention and prophylaxis, the role of AIT drugs. So I was initially sharing wrongly. So now once again the same theme I already told. So overview: the sex is a natural instinct. Siri, am I audible? I am. My slides are visible.
Yes, sir. You're perfectly audible, and your slides are also
Okay,
visible.
okay. Sex is a natural instinct for all living creatures. Sex with multiple partners have a definite risk for HIV and sexual transmitted infections. HIV is transmitted through exchange of body fluids. It can be transmitted through body fluids like blood, semen, vaginal secretion, not through saliva, urine, or something like that motion. Lifestyle modification nowadays, because of these lifestyle modifications of human being, increases the chance, increases the risk for HIV. HIV is, of course, preventable, definitely. Prevention is better than cure, as with any other infections, non infectious disease. Infectious disease has a public health aspect and important to the family and the nation. Moreover, HIV is a stigmatized disease. A sterilized cure is yet to be achieved. So chronic lifelong disease as on date affects the economy of the individual, their family, and also the nation. So it's a very important thing to be prevented. The modes of transmission of HIV, so nearly 75 to 85% are getting the infection through sexual route. The sexual route may be GOA, genital, genital oral, or genital anal. And so this anal sex has a more risk than vaginal sex and oral sex. Transmission through blood and blood products is also is a known entity. Blood transmission nowadays is very very careful. All the blood without examination for without screening for HIV and STI it's not being given. But in spite of that, sometimes the patient is in the donor. There's a window period. It's a possibility. There is a possibility is there. Sharing syringes and shops, IV drug abusers. So there is also in the IV drug abusers are there. So when they are sharing the syringes and shops, it can be transmitted. Mother to child transmission is also no known entity. Occupied occupational exposures is very very rare, but it's possible in among the medical community and also the lab people. HIV is an absolutely preventable. The preventive measures are we can enumerate as A, B, C, D. A for abstinence, abstinence, sex, abstain from the sex before marriage. B for be faithful to your partner. After marriage, be faithful to your partner, as our culture taught already. C for condom. If one cannot adopt the both first two, he should not forget to use condom as a barrier protection, and it will give ample protection from HIV and STI. D for drugs. So, which is the topic for today? Drugs. With the help of the drugs, we can prevent HIV. In how that is, we'll discuss later. Others, safe transfusion measures, precautionary measures, supplying fresh syringes and needles to the drug abusers, supply of lubricants. All these things also play a role in prevention. Importance of prevention and prophylaxis of AIDS already told. You can avoid so many lifelong drugs. If once acquired HIV infection, he has or she has to take treatment for lifelong. It's a chronic affair. We cannot stop like that of diabetes or hypertension or heart disease, something like that. So, if we are able to avoid HIV acquirement, we can avoid these lifelong drugs. Good quality of life is assured. Hospitalization can be minimized. Avoids the restriction in your lifestyle. Avoid mental tension. Avoids fear and transmitting the infection to your near ones. Drugs act as prophylaxis. In what way it helps? That is post-exposure prophylaxis after the exposure, whether it is occupational or sexual exposure. Pre-exposure prophylaxis. Who are all need pre-exposure prophylaxis? Let us talk. Prevention of parent-to-child transmission. Lastly, U is equal to U. That is, undetectable is equal to untransmittable. The ART, when we started, the patient is adhered to treatment. The patient is after 24 to 48 weeks, he is becoming, if the ART is correct, appropriate, he will become that is undetectable viral load. The bloodstream virus will not be there. So thereby he is no longer infectious to his partner or anybody else. So that is called as undetectable is equal to untransmittable. And occupational exposure, also we can give post-exposure prophylaxis. Post-exposure prophylaxis, the name itself implies what is the role. Actually, the post-exposure prophylaxis originally devised only for occupational purpose, for the lab people or accidental needle prick of the doctors or something exposure or splash of infectious fluid over the face or eye. So this is mainly for occupational exposure, but nowadays it is being used also for sexual exposure also. All healthcare providers who come in contact with the blood and body fluids in hospitals and laboratories are vulnerable for the HIV acquirement, occupational exposure. Nurses, nursing students, laboratory workers, doctors, residents, paramedics, emergency doctors, medical students, dentists, dental students, cleaning staffs. What is the risk? The needle prick has 0.3% chances for infection, whereas the splash or the mucous membrane is just 0.9%, 0.09%. Sexual transmission is around 1.0018% to 3%. Mother to child is 25% in the long run. Infected blood products 95%. So these are the chances, especially blood transfusion, 95% infection chances are there. But when compared to hepatitis, it is less risk only for blood transfusion. The factors influence the risk are depth of the injury, size, and type of the needle. That is why that is hollow needle is more dangerous than the solid needle, because in the hollow needle it contains more amount of fluid retained. The device visibly contaminated with blood. Procedure involving needle placed in the artery or vein. Anything, angiogram or something like that, invasive procedures. Area and quantity of exposed in the splash, where it is exposed, not in the skin, mucous membrane, eye, and amount, all these things accounts. And source of the patient, source the wire load is also very important. That is source means from which we are at the risk, whom we are getting the infection like that. So implementing PEP protocol, there is a protocol for post-exposure prophylaxis is drawn by international bodies. Access to experts during all hours. So the proper consultant should be available at every hour, because night and all operation could be undertaken, emergency operation. So somebody who is responsible should be available round the clock. Availability of the antiretroviral drugs also should be there in all hours. Availability of the experts who has to decide whether to take PEP or not. Availability of the trained personnel for counseling before taking the ART drugs for PEP. Also, one needs counseling. What is the importance of adherence? What is the side effects? All these things. We should not drop in middle. Availability of the testing facilities. So that is also should be available. That should be available at all time. Assessments before starting PEP. Clinical assessment of the exposure, how depth, whether it is really infected material, and all these things, whether the patient deserve to be on PEP, eligibility assessment, HIV testing for the exposed individual, and the source. The individual also should be HIV negative. Already, if the patient, if the individual is HIV positive, there is no role for prophylaxis. The patient has to be put on treatment forever. At the same time, the source, if you are able to see the source is negative, the need for PEP is not there unless the patient is having a, you are suspecting could it be he was in window period. And provision of first aid to the wound is necessary as that of the um, dog bite wound like that. Risk of HIV and benefits of PEP has to be assessed and PEP has to be started. Adherence counseling. The PEP has to be taken for 4 weeks. So the patient has to be taken daily, correct time, and the importance. If he drop out from this in the middle, there may be drug resistance may likely to be possible, and in future, if he develops HIV, it may not be suitable to continue all these things. So, special support for sexually assaulted individuals. So the PEP is also very important for the child abuse, sexual assault cases. So we have to give PEP and that patient also. So we have to counsel and assess the importance, assess the other diseases also. Treatment of exposure to immediate measures. Use soap and water to wash the wound of the skin, wound or skin, and flush exposed mucous membrane with water, the eye, the mouth. Repeated washing, repeated gargling is very useful. Encourage bleeding, if any, by pressing around the wound. And open wounds, disinfect the wound solution with a disinfectant solution. We can disinfect the wound. Eyes to be should be irrigated with clean water. Report to the concerned authority. Counseling, antiviral therapy has to be started as PEP. Therapy should be recommended after exposure as early as possible. 3 drug regimen has to be given. Previously, 2 drugs also was recommended, but it's not so. Now 3 drugs has to be taken. And source patients' HIV status, whether it is known or unknown, that's also matters. Decide on case-to-case basis. Follow counseling and HIV testing using ELISA periodically for at least 6 months before starting the treatment. Baseline 6 weeks, 12 weeks, and 6 months. Only after 6 months we can declare the patient was free from HIV. Potential benefit should be weighed against potential risk. And follow PEP after 72 hours is useless. If you want to give PEP, it should be started as early as possible, not later than 72 hours. A verbal consent should be got after the explaining the risk and benefits of the PEP. PEP has to be continued for 4 weeks without interruption. So patient has to be given the drug, information about the drug's side effects, importance of the adherence, regular follow-up for 6 months. All these things should be given, counseled, and prepare the individual to for PEP. So that is very important. Why this is 72 hours? So window of opportunity, that is 72 hours is a window of opportunity by which time we can abort the disease. There is possibility. After 72 hours, disease will be established. We cannot do it. So the first 24 to 72 hours, HIV crosses the skin or mucous membrane taken up by the dendritic cells of the skin epidermis to the regional lymph node where it enters into bloodstream. 48 to 72 hours, getting picked up by dendritic cells attached to the CD4 receptors of the WBC in the circulation, and there is T4 cells, and fusion takes place. Co-receptors CCR5, CXCR4 also will play apart from the CD4 receptor, and the viral core enters into the cell, leaving behind the viral coat. Only the viral DNA enters with the enzyme and other viral particles, and from the cytoplasm it enters into the nucleus by the process of transcription or integration. So once the virus get entered into the host cell nucleus, infection is said to be established, all within 72 hours. Then it is irreversible. So there is no role for PEP after that 72 hours. So before 72 hours, before it gets entered into the nucleus, even the cytoplasmic stage we can prevent. Even the entry or attachment we can prevent. And the carryover, if can with transmission or there is a transport, we can prevent. Once gets established into the nucleus, we cannot prevent. That is the idea of the we have to start before 72 hours window of opportunity. When the individual is already HIV positive, there is no role for PEP. When the source is established to be HIV negative, there is no window period. He was not having any recent exposure within 3 months, and exposure of the body fluids that does not pose significant, for example, saliva, tears, urine, stools. So they are not infective material. 72 hours after the exposure also, there is no role for PEP. So sometimes the condom broken, condom slip or something like that, the patient used to tell. So these patients are also having some problem. And the positive HIV partner, sexual partner, where the patient is already on treatment, whether is a viral load is undetectable or like that, we have to assess the need for PEP. And the condom in use is correctly maintained, and sexual partner uses HIV medication, and or he is not HIV reactive, no need for PEP. So normally the PEP contains a integrase inhibitor, either raltegravir or dolutegravir. Raltegravir 400 mg twice daily, or dolutegravir 50 mg once daily, and plus a nucleotide inhibitor, tenofovir diperoxyfuramide, and also M-tricytabine 200 mg. So this is 3-drug combination. One tablet is a fixed drug combination, one tablet daily for 28 days. Some side effects may be there. Most of the patients are tolerating well, not to worry. Every drug will be said to have side effects, but most of the patients are tolerating well. And if the patient is already having renal compromise or something like that, renal dysfunction, tenofovir is contraindicated, then we have to use zidovudine, lamivudine combination. So these are the drugs we are using for PEP. Further counseling, intermittent counseling before starting, then also whether the patient is adhered to treatment, whether he is taking, whether he is having side effects, he should not stop it. All these things we have to do it up to 6 months. And the patient should not donate blood or organ, and as far as possible avoid sex or barrier sex, use barrier sex, and avoid becoming pregnant, tissue donation. All these things should be avoided till 6 months. After 6 months, we can declare the patient is free. Monitoring and management of PEP toxicity. PEP is used, healthcare providers should be monitored for the drug toxicity by testing the baseline, again 2 weeks after starting PEP. HCP is taking antiretroviral drugs should be evaluated if only acute symptoms develop while receiving therapy. Usually, most of the patients are tolerating well. Very rarely, such symptoms may occur. Minimally, laboratory monitoring for toxicity should include a complete hemoglobin, complete blood count, renal hepatic functions. If the toxicity is identified, modification of the regimen should be considered with the help of the expert. So this is about post-exposure. Now pre-exposure prophylaxis. It's also 99% effective. Whom we have to suggest the pre-exposure prophylaxis. So it is mainly for the discordant couple. One pair, one husband or a wife is reactive now, whereas other partner is not reactive. So that is a discordant couple. So we have to the discordant couple, the uninfected partner should take the pre-exposure prophylaxis, because the sex can happen at any time, so it cannot be controlled. So the pre-exposure prophylaxis should be given for the uninfected partner of the discordant couple, male sex with men, so they are highly promiscuous, female sex workers, IV drug abusers, and their spouses, highly promiscuous individuals, all people may be or ideal patients, ideal subjects to have pre-exposure prophylaxis. Drugs used for pre-exposure prophylaxis: two drugs: tenofovir disproxyl fumarate 300 milligram, M-tricytabine 200 milligram once daily. Fixed dose is there, one tablet daily. So here there is no time limit. In PP we have to give 4 weeks, but is these patients at any time the sex can happen, so they are always at risk. So these patient has to take the drugs forever as long as they are sexually active. That is the important thing. Tenofovir gel is also where was available, and that can be applied, and then they can have oral sex or anal sex, more effective along with the safe sex. If it is used, this pre-exposure prophylaxis with the barrier, that is condom, it is more effective, 100% effective. And pre-exposure prophylaxis has to be taken daily as told rightly, not recommended as a demand basis, but especially for the people high risk, along with the protected sex, it is 99 to 100% protection. Recent that is another NNRTA, this nucleoside inhibitor, non-nucleoside reverse transcriptase inhibitor are there. It is called dapivirine. Vaginal ring was available. If they are where they can have sex. So this is mainly for sex workers, and it can be used not for the high risk people. Demand, prep demand. Actually, there is a thing is called as prep demand, prep on demand, but I will not recommend for that. So this will increase. This will give false confidence. The patient may have highly promiscuous. They may be prevented by HIV, but they may likely to acquire other STI. So my personal belief is it's not advisable, and 86% is effective, is said to be effective for HIV prevention, but HIV prevention not the other STIs. Two tablets first day, one tablet subsequent days, so 4 tablets. So this is the 2 tablets to be 2 to 24 hours before sexual act. One tablet has to be taken 24 hours after the first dose, and another for the 24 hours after the second dose. So this is the regimen for prep on demand. So I want to go to some lady, I want to have sex with a man, so I can take this. So this is prep on demand, but it's my personal opinion is not to be recommended. Then prevention of parent to child transmission. So mother to child. So routine offer of HIV counseling and testing should be given all pregnant mothers in antenatal care at least twice during the antenatal period. I ensure the involvement of spouse and other family members also, if they are reactive or something like that. Provide ART to all HIV infected pregnant women regardless the CD4 count results. Treat them with the complete therapy, adequate therapy. And preferred regimen is tenofovir, lamivudine, and dolutegravir. Promote institutional delivery for all the HIV infected patients, no house delivery or something like that. Provision of care of associated condition for STI, RTA, tuberculosis, any other opportunistic infection also has to be attended, has to be detected, has to be diagnosed and attended properly. Provide nutrition counseling and psychosocial support for HIV infected pregnant women. Provide counseling and support for the initiation of exclusive breastfeeding within an hour after delivery, or preferred option for the continue for 6 months. After 6 months, complementary feeding can be allowed. Infant feeding risk factors influence PTC. There is parent to child transmission. Mother is infected when the HIV while with the HIV while breastfeeding. So child is have a risk. Breastfeeding, pathologies, cracked nipples, mastitis, and engorgement increases the risk. Advanced HIV disease in the mother. Poor maternal nutrition, mouth sores, and or an inflamed GI tract in a baby. So these are all potentially increases the risk. Mixed feeding, breastfeed along with the other foods. See, exclusive breastfeeding in the HIV mother till 6 months at least. Prolonged breastfeeding for 6 to 18 months also have some risk. Interventions during pregnancy, primary prevention of HIV in childbearing women and provide HIV information to all pregnant women and natal visits or opportunity for PPTCT, prevention of unwanted pregnancy in HIV positive and prevention of PTC, there is parent to child transmission through ART, so safe obstetric practice. So when we are adopting all these things, we can prevent the birth of a infected child. Interventions during labor and delivery also is very important. Minimize vaginal examination, avoid prolonged labor, consider using oxytocin or induce labor, avoid premature rupture of membranes, avoid unnecessary trauma during delivery, use non-invasive monitoring, fetal monitoring, avoid invasive procedures such as scalp electrodes, scalp sampling, avoid routine episiotomy, minimize the use of forceps and vacuum. So all these things, invasive procedures as far as possible, we have to try to avoid or minimize. Consideration regarding mode of delivery, cesarean section has to be performed before the onset of labor and before membrane rupture. That is an ideal thing. And the risk of elective cesarean for PMTCT should be assessed carefully in the context of factors like such as risk of post-operative complication, safety of blood supply, cost. So all these things keep it in mind, and accordingly we have to decide. In India, normal vaginal delivery is recommended unless the woman has obstetric lesions for a cesarean, another any indication for cesarean section. Otherwise, we can allow them to have normal delivery. Use of ART can reduce the risk of parent to child transmission better and with a less risk for cesarean section. Intervention during infancy over observe for the signs and symptoms of HIV and follow up is very necessary. HIV exposed infants should be received co-tremoxyl chemoprophylaxis for 4 to 6 weeks. Follow standard immunization schedule, routine baby visits, DNA PCR, 18 months visit for HIV testing. So, because the passive transmission from the mother to child also is possible. So, 18 months with the antibodies present, even after 18 months, it should be babies already got infected. That's why we have to follow up for at least 18 months. Safe breastfeeding, infant feeding, exclusive breastfeeding, support good breast health without any breast pathology, replacement feeding if affordable, feasible, acceptable, sustainable, and safe. That is exclusive replacement feeding if it is possible, if they are affordable, if they are educated, they are understanding, sustainable, all these things we have to keep it in mind and we have to advise accordingly. Avoid addition of supplements or mixed feeding which enhance the HIV transmission. Antiretroviral prophylaxis therapy, ARV prophylaxis, short-term use of antiretroviral drugs to reduce the HIV transmission from mother to child, and ARV therapy, long-term use antiretroviral therapy to treat maternal HIV and PPTCT. ARV during pregnancy decrease the HIV viral load mothers, so the baby will be free from the infection. Antiretroviral prophylaxis monotherapy, nevirapine for the mother at the time of delivery when the mother came the late, so we can give single dose of nevirapine 200 mg at the onset of labor. Baby also has to be given syrup nevirapine 2 mg per kilogram body weight within 24 hours of delivery. So goals of PPTCT: primary prevention of HIV among the women, childbearing age, prevention of unintended pregnancies among the women living with HIV, prevention of HIV transmission, the child from transmission of the child from the infected mother, provide care, support, and treatment to the women living with HIV and their children and family in women childbearing age. Infant care, provide antiretroviral prophylaxis to infants from birth up to minimum 6 weeks when the baby was exposed to HIV from the mother. Ensure initiation of co-triamoxal prophylaxis, chemoprophylaxis, and also we have to do HIV DNA PCR at 6 weeks of age, and also after 18 months, provide counseling support for initiation of exclusive breastfeeding within an hour of delivery and as preferred option, and continue for 6 months at least. After 6 months, complementary feeding can be given, and family planning services for the parents should be advised. Take home message: HIV is completely preventable. Awareness activities have to be geared at all clinics. Post exposure prophylaxis, pre exposure prophylaxis available widely, easily. Consult experts and avail it. And HIV transmission through mother to child is preventable. Antenatal mothers have to be screened for HIV and syphilis twice during pregnancy. Support service, repeated counseling to the HIV positive mothers is mandatory. Counseling about the infant feeding is also has to be provided. Thank you very much for your patient hearing. If you have doubts, it will be my pleasure to clear it.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Yes.
So, sir, the first question is, how do we counsel newly diagnosed patient regarding ART as preventive tool for their
Can you
partners?
can you post it in the screen?
Sure, sir. Should I put it in the chat box so that you can read it out?
Okay, I'm not seeing this chat box. How to come out of
On the
the?
right hand side of your screen, I have put up the question as a private chat box which is coming.
I'm not able to see.
Should I repeat the question, sir?
Yes,
Yeah. The
yes.
question
Now
was,
I'm seeing the chat box. Yes. How
yeah,
do we counsel newly diagnosed patient regarding ART as preventive tool for
partner.
for their partners? First of all, we have to, after diagnose HIV, we have to counsel the individual, prepare the individual for a ART drugs, and we have to bring the family members, especially husband or spouse or wife, and we have to counsel them. And as I said, if there is a discordant couple, pre-exposure prophylaxis is indicated. We have to advise them what is the importance of pre-exposure prophylaxis and how to take daily taking. What is the advantage? What is if it is not there? How what is the risk is there? All these things we have to explain. And once the patient individual who is on ART becomes undetectable viral load, the risk is less. But initially, we don't know whether the ART is appropriate or not, and so we have to confirm whether the viral load completely undetectable. Then the risk is less. But till then, the patient has to take pre-exposure prophylaxis and the proper treatment. All these things we have to counsel and prepare the patient, and we have to give.
Thank you so much, sir. Next up, we have, yeah. What challenges do clinicians face when initiating rapid ART within 24 hours?
Within 24 hours, that is,
Yes, sir.
as I told, the expert should be available, the counselor should be available, the drugs should be available. If it is an odd hour, 11 o'clock, after that 9 at night, so maybe the consultant may not be there, the appropriate expert, whether it has to be started the post prophylaxis treatment, and the testing facility, drugs facility, counseling facilities, all are there. So it is all, if it is provided everything, it is very simple, easy going, and we can start as early as possible. So at least we can do it within 24 hours. That is possible. One more thing is, if it's Sunday, if it's Sunday means Saturday means Saturday night means Sunday also we cannot be able to get the drugs or something like that. So all these things, if we are provided, if the tertiary care center is provided all these facilities, well and good. Otherwise, we can make some other arrangement for the doctors who are handling the disease, make some arrangements how to get, where to get immediately. All these things are possible. That is possible, but not in all centers.
Thank you, sir. There is one last question left. What baseline investigation are mandatory before starting PREP?
Routine in what is the investigation?
Yes, sir. What baseline investigations are mandatory before starting PREP?
That is that is mainly the pre or post exposure prophylaxis. We have to do basic investigation, like for anything we have to rule out HIV. First of all, when the patient is already having HIV infection, there is no role for prophylaxis, either pre-exposure or post-exposure. So no role for that. Then we have to assess the patient comorbidity, whether the patient is having renal morbidity or some other thing, whether the patient is on drugs for TB. So some drug interactions may be like that. And in kidney patients, we cannot give tenofovir. So some drugs may be offensive. For example, nevirapine cannot be given if the liver is involved. So we have to assess the almost renal function, liver function. All these things has to be assessed, and complete hemogram, whether the patient is already having anemia or anything, and the viral load and CD4 count, everything. On the basis only, we can select the appropriate drugs which can they can continue easily and freely without any complications. That's a method. Almost we have to screen the patient routinely for normal general checkup.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Before concluding, any take home message from your end?
So today is HIV AIDS Day, and we everybody, every doctor, if they are having some interest and update themselves, they can treat the patient. So it is a treatable disease. So it is the patient, when the patient is taking treatment regularly, they can have a normal life. Suppose if the patient is a diabetic, may even their blood glucose is level control is leading normal level, normal life. Like that, the patient can lead a normal life. He can take care of his family, he can earn, he can look after his children. Everything is possible, and their life expectancy also, when their patient is appropriate antiviral drugs, they can live as a patient who is not having HIV till 75, 85. So there is no problem. So these are the message. And moreover, these patients, HIV patients, by touching, by sharing them, sharing their utensils, tumbler, plate or bathroom, is not infectious. Only their blood and uh, semen or vaginal fluid is infective. So all the other things is not infective. So there is nothing to be stigmatized. They can be taken care by us. It is not to discriminate them. So these are the message I want to give this AIDS Day. Thank you very much.
Thank you so much, sir, for this wonderful presentation and for such a wonderful talk. It's our pleasure to have you here, sir. Thank you so much for joining us today.
Thank you.